Good afternoon, everybody. This is Anthony Nappy, the nurse liaison for the Virginia Impact Project. We'll get started right on time. This is session 5 of our virtual learning series. Thank you, everyone, for attending. And I'll start by introducing our medical director, Dr. Laurie Archbald-Pannone.
Thank you, Anthony. Appreciate that. We are very excited to have you all join us today for our 6th session of Impact. Today, we will be discussing the birds, the bees with artificial knees, STIs in long-term care. We're very excited to welcome Dr. Aval Green. I've known Dr. Green for a very long time, almost the last millennium, but we're excited to have her here with us today. She is a fellowship-trained geriatrician who holds board certification in 3 specialty areas: internal medicine, geriatric medicine, as well as hospice and palliative medicine. After completing both residency and fellowship training here at UVA, she served on faculty here at UVA, focused on geriatric clinical practice, as well as geriatric teaching and medical education. She now serves as assistant professor of medicine at Texas A&M College of Medicine. She leads as division director of geriatric medicine, medical director of hospice at Baylor Scott & White in Temple, Texas, is a member of the board of directors at Scott & White Clinic, and has recently completed her master's degree in healthcare administration from Texas A&M School of Public Health. So you can see why we're so excited to have her with us today. We had planned to have Dr. Warren join us today as well. You may remember Dr. Warren. She led us in our 2nd impact session entitled Dealing with Diarrhea, It's Everyone's Responsibility. If you missed that, you can see that link on our website. She was to join us today in her role as one of our lead STI testing specialists here at UVA. Unfortunately, she is ill and not able to join us, so I will do my best to present her slides in her stead. And if you have questions, especially questions perhaps that we can't answer today, then please send them to us either through the chat or through our Impact email address, and we'll work to get with Dr. Warren to make sure we get all of those questions answered for you. In terms of the discussion today, we really want to have a discussion as opposed to a presentation. We really want to engage with you all to present some of the information, but really to hear from you and to work through some of these challenges together. So with that, let's see. All right, are you able to see the slides on my screen? All right, so Dr. Green, Dr. Warren, and I have no relevant conflicts to report. And with that, I will turn it over to Dr. Green to get us started.
Thank you, Laurie. Are you all hearing me okay?
Yes.
All right, good deal. I am so excited to be here, and I really appreciate the opportunity to spend the lunch hour with you talking about the birds and the bees with artificial knees. I'm not in San Francisco. I'm actually sitting in my car outside the nursing home. So I am a frontline provider in the trenches, still teaching. I've got a medical resident sitting right next to me in the car, Dr. Garrett. So we're doing this together, but living the life, living the dream, and loving every minute of it. So thank you for the invitation, Laurie. I really appreciate it. You can go to my first slide. All right, so we're going to jump right in with a case. And the cases that I'm presenting for today's talk are actual cases that we've encountered here. And I think this is important because that's how we learn, that's how we think, and that's how we apply the information. So we've got an 82-year-old male who was admitted to the hospital with severe diarrhea and adult failure to thrive. His workup included a diagnostic colonoscopy, which was positive for CMV colitis. And folks found that a little interesting. And so that led the team to dig a little deeper, broaden their workup, and they tested him for HIV, which came back positive. They were shocked because he's an 82-year-old man. He was single, but was the father of adult children, independent, and it was not previously noted in his social history that he had risk factors for HIV, and it's not one of the things that we tend to think about. His family was not aware, but he had been involved in same-sex relationships, and everybody was surprised, including the medical team. And he asked the medical team if they would help him not only disclose his diagnosis to his family, but to also share with them the aspects of his life that he had kept hidden. And so this case occurred here a few years back, but definitely relevant for today's discussion. Next slide. So here's a pop quiz. I'm going to see if I'm dating myself. Do you know who this guy is? And if so, you can type his name in the chat. I wish I had prizes to give out, virtual prizes, but I don't. But it reminds me of a game show. That's right, Liz. Liz says Chuck Woolery. That's so he was the host of Love Connection, if you remember that game show. But that's what I thought about, because seniors are making love connections. And I think it's something that we as healthcare providers need to be aware of, because we want to make sure that we're treating the whole person. And we can't do that if we ignore the sexuality that's a natural part of life, including later life. Next slide. So when you think about barriers and facilitators of sexual expression in later life, our patients go through a lot of changes. So the barriers they might find are loss of a partner or spouse, to death or divorce, medical issues that make it challenging for them to engage in sexual expression. That could be anything from arthritis of the hips that makes it a little bit more complicated to get into the positions they enjoy, or even vascular disease, which we know is associated with erectile dysfunction, diabetes, things like that. Some of the drugs that we use to treat their chronic comorbid conditions have as a side effect low libido or sexual dysfunction. And then ageism. People just don't want to think about it. They don't want to consider that our aging adults are still very much sexual beings, and that can be a barrier to sexual expression. Decreased mobility, the ability to get around, not only in your home, but outside of your home. If you're no longer driving, it's hard to meet up with people and go to dinner and date and those sorts of things. And most folks don't want their adult son or daughter chaperoning their dates. But at the same time, there are facilitators of sexual expression. So congregate settings, which is what we're going to talk about today. People living in the same space, having an opportunity to get to know each other on a daily basis, can offer them an opportunity to make some connections. Treatments for sexual dysfunction have really taken off, and direct-to-consumer marketing has had a big impact in this area. You cannot watch a football game or your favorite sitcom or anything without knowing what to do when the time is right? So those commercials are very pervasive, and they all end with ask your doctor or healthcare provider, right? And so there are a lot of treatments out there available. Do not underestimate the power of social media and online dating. So historically, or not historically, anecdotally, I guess you could say, people think of older adults as not being very tech savvy. That is changing. That may have been the case 20 years ago. It is not the case now. So there is social media. Older adults are getting online. There are dating websites just for people over the age of 65. Cell phones are ubiquitous. Everybody has one. And so at the touch of a button, you can swipe left, you can swipe right? And so you have access to other people in a way that we did not before. And then for those transportation issues, who's ever called an Uber? You can get an Uber or a Lyft to take you anywhere. So if you want to go out on a date, and you're no longer driving, or if it's not safe for you to drive, or if your children took your keys, because that happens too, you can Uber to a date. And then there's a cultural evolution, which I think was probably at play in that first case that we talked about, because our older adults sort of grew up in a totally different time culturally, where there are things that were not acceptable when they were younger and coming of age sexually that are now more socially acceptable. And so they may have led a life very different in their younger years than they are able to live now, which is what I believe was going on with the case of the 82-year-old gentleman who was, HIV positive, clearly had risk factors, but no one knew and everyone was surprised. Next slide. All right, so here is my next case. And y'all know these ladies. This is another pop quiz. If you know this show, plop it in the chat. The resident sitting next to me has never watched this show. I was like, you have got to get on Hulu. Yes, the Golden Girls. I love the Golden Girls. And my favorite Golden Girl, well, I'm not going to tell you. We can talk about that when we get to the but we all know which Golden Girl was the one who had the reputation for being very vivacious. But they all, in the storyline to the show, they all had relationships, romantic interests. A lot of the plots were about sexual expression. And I think that's one of the reasons that it was so enjoyable, because it gave us an opportunity to look at older women in particular in a way that was different than how we had been looking at them before. So this is a real case, but of course I changed the names to Shady Pines Nursing Home, because that's the nursing home Sophia was in on the show. But the staff at Shady Pines Nursing Home has reached out to the medical director because Theodore, a 65-year-old male resident with cerebral palsy, has taken a liking to Miss Petrillo, who is wheelchair bound due to stroke. He is often seen stroking her face and kissing her on the forehead and the cheek. When asked if she enjoys the attention, she replies, "Sometimes." Now, this is an actual case of mine. And what the staff was concerned about is that this younger resident who was there because of cerebral palsy was still very much interested in sexual expression, and he would find female residents who didn't mind being touched and hugged and kissed, but they were worried about whether or not she had the capability of consenting to it. And that's when they asked me to get involved. So when I went and talked with her, my conversation was like this: "Mrs. Petrillo, I understand that you and, Theodore spend a lot of time together. Tell me how that's going. Do you enjoy that?" And she said, "I do. I enjoy that." And I said, "Well, the staff has noticed that sometimes he strokes your face and he kisses you on the forehead and the cheek. How do you like that?" And she said, "I like it sometimes." So then I said to her, "Well, what do you do when you don't like it or you don't want him to do those things? How do you deal with that?" And she said, "Oh, I just tell him to go play bingo." And I said, "Does he listen?" She says, "Yeah." Clearly, she was very much aware that, she could tell him no, and she knew how to do that. She felt very comfortable with that. So then we brought in the representative parties, the families of these residents. We had a care plan around it to talk about their relationship. The families were okay with it. And we just had to make sure that her wishes were being respected, even though she had some cognitive impairment. That did not mean that she lacked the ability to consent to certain things, the decision-making capacity to consent to certain things. So we had to sort of navigate that. And eventually she moved to a different facility, and he was very sad until he found another lady who didn't mind being kissed and, having her cheek rubbed. So it was really, really sweet. But it definitely brings up some other considerations that I want to talk about as well. Next slide. So this issue of sexually inappropriate behavior comes up a lot in long-term care and in congregate settings. And I think we need to ask ourselves some questions about that. I actually just got sorry about that. My car went off. Let me turn it back on. Okay. I just got a consult this morning for someone who was exhibiting sexually inappropriate behavior. And so I like to ask, who's the target? What's the setting and what's the intent? Because clearly, if you're dealing with a person who's living with dementia, they don't have the executive function to often determine where the appropriate settings are and who the appropriate targets are. And if any of you have ever watched some of Teepa Snow's videos, she does a really good job of talking about this, that sometimes we are unintentionally putting our residents in a situation that stimulates provocative behavior. So the example that she gives is the caregiver who's wearing a pair of scrubs with a V-neck. I mean, how many of us have scrubs with a V-neck? And perhaps this person is well endowed and they come in to help Mr. Smith and they bend over because they need to fix the wheelchair. Well, now Mr. Smith is looking at their cleavage, right? And so you can sort of understand how it might inadvertently lead to the expression in the moment. And so I put it in quotes because I don't actually like this term, sexually inappropriate behavior. I think a better term is socially misplaced sexual expression, right? And so sometimes you have to care plan around that. And it involves educating caregivers about the things that they may or may not be doing that might be triggering some of this behavior in our persons living with dementia who no longer have the executive function to monitor that for themselves. And so you have to care plan around it. And so we've already talked about cognition. Are we dealing with the initiator? Are we dealing with the recipient? Are we dealing with both? Is it mutually agreeable activity between the both of them? If not, does that person understand that they have the ability to say, I'm not interested today? How do they communicate that? Are the families involved if you have someone who requires a surrogate decision maker? All of those things are really important to consider when you are looking at sexual expression in congregate housing. Next slide. Thank you. So as we talked about, because older people are still very, very much sexual beings, and because of all of those facilitators that we've seen in over the years, we are now seeing an increase in sexually transmitted infections among older adults. And Laurie will pick this up for me here in a little bit, but I'll tee it up by saying that they are less likely to get tested because there's a stigma surrounding it. They may also feel, again, because of ageism, that they're at less risk, but they have more access to treatments for sexual dysfunction. They have more access to other seniors, even if they're not in a congregate housing situation. They can get access through online dating platforms and transportation services, all the things that we've mentioned. Plus, there may be some issues related to executive function that keep them from exercising prudence in how they express their sexual desires. Next slide. And so one of the things that we've seen over the years, starting in about 2010, is an increase in chlamydia, gonorrhea, and syphilis in people over the age of 65. It's the fastest growing segment of our population when we look at the incidence of sexually transmitted infections because of all of those things. And so what that means is we have a responsibility as healthcare workers and healthcare providers to be aware, to educate ourselves, to get comfortable being uncomfortable and having some conversations that we maybe would rather not, because we're over identifying with the people we're caring for. We're thinking about a grandma and a grandpa, but that's not who that is. And even your grandma and your grandpa are still sexual beings, even as they age. So we're going to have to change the way we think about it, because people's health and well-being is at stake, as indicated by these graphs. Next slide. And this may be one of my last slides, if not the last one. And so the misconceptions and missed opportunities that we need to address are in the area of risk mitigation. I did a study when I was a resident physician, or maybe I was a geriatric fellow. I can't remember, but it was a study looking at the attitudes of older adults towards sexual expression. And when we talked about the use of condoms, it was not uncommon for them to say, oh, no, I don't need condoms. I can't get pregnant. Because in their mind, that's the primary use of a condom, is to prevent pregnancy. And so we had to back that up and talk about sexually transmitted infections. That is still a pervasive belief that they don't need to use condoms because pregnancy is not an issue. And then there are all the symptoms that get attributed to other things. So older adults are not immune to the Dr. Google syndrome. Oftentimes, when they have symptoms, they've already made the diagnosis themselves. They're coming to you to tell you what they think you need to do about it. And if you don't stop and take a bigger view, make sure that you're doing a good social history, then you may miss clues that you need to be looking at other things, right? So they come and say, I've got vaginal discharge. I need something for a yeast infection. Well, maybe it's not a yeast infection. It's easy to write that prescription for a yeast infection, but I think important to consider other things. Oh, it burns when I urinate. I've got a urinary tract infection, right? Dig a little bit deeper. My abdominal pain is constipation. My diarrhea is my irritable bowel. Well, we saw in the first case, it was CMV colitis plus HIV. So we just need to broaden our history taking and make sure that we're considering in the differential diagnosis sexually transmitted infections, because if you don't think about it, you will miss the opportunity to diagnose it. Is that my last one? It is. I'm going to turn it over to my partner, Dr. Archbald-Pannone. Thanks.
All right. Thank you so much, Dr. Green. I'm going to go through some kind of ways to think about approaching patients that may have symptoms, to start to think about treatment options, as well as to put forth a lot of great resources that are available. Mostly the ones I'll focus on are through the CDC, that are available in a lot of different forms to really be helpful in real time. I'll go through these slides, and then I'd like to leave time at the end for questions and discussion as well. So again, we're going to be talking about STIs in long-term care. These slides were compiled by Dr. Warren that I will be presenting today. So as Dr. Green pointed out, we've seen an increasing incidence of STIs over the past 20 years, with almost 2.5 million new cases of STIs in 2020. And a lot of different STIs are going up, and a lot of STIs are going up in our older adult population. And so 10%, this is looking at HIV infection in 2018, and 10% of folks in America diagnosed with HIV infection are over 55 years of age. And so our older population is seeing a significant amount of HIV for diagnosis. When we're talking about sexual history, and Dr. Green did a great job of, kind of talking about that environment that we need to create when we're discussing with our patients. First of all, we have to think about asking a sexual history and ask a sexual history. And there's some tools to help us to do that. So we want to create a welcoming, non-judgmental environment that is respectful and open to ask open-ended questions and to hear and listen to, whatever it is that our patient has to share with us. The CDC puts forth what they call the 5 Ps. The 5 Ps is their kind of tips for for healthcare providers how to approach taking a sexual history. I have the link here. It'll be in the slide sets that will be sent out after this, as well as available on our website. So the 5 Ps that the CDC focuses on for taking a sexual history, or to kind of help give us framework when we're taking a sexual history, are part of a guide that they have, a guidebook, but specifically focusing on partners, practices, protection from STIs, past history of STIs, and pregnancy intention. Now, as Dr. Green mentioned, in many of our populations, perhaps pregnancy is not physically within consideration, but nonetheless, how people are thinking about sexual acts, sexuality, and pregnancy is still important to talk about, and especially many of us have younger patients as well. So it's important to think about those 5 Ps. I've listed here on these next few slides the specific questions that the CDC kind of puts forth as examples of how to explore the 5 Ps. I'm not going to go through each individually, but I wanted you to have them in the slide set for reference afterwards. But again, partners, practices, protection from STIs, past history of STIs, and then pregnancy intention are the 5 Ps to think about, and then different questions to work through. How are we going to ask our patients about this, and how are we going to listen to the answers that they give us? So when we're talking about sexually transmitted infections, there are some that are quite common, some that perhaps are less common in some populations, but there's a lot of different types of sexually transmitted infections. When we're talking about that, we're talking about a lot of different things. The CDC has just put forth recently in 2021 guidelines about treatment of sexually transmitted infections. I wanted to put this slide up specifically just to start thinking about, what's that mean when we say STIs? It's easy to kind of say that term, but what really are we potentially thinking about? And so I wanted to list them out there. Again, there's the accessible version online because as you can imagine, treatments are both specific to the specific infection as well as can get complicated. So the CDC recommendations for STI treatment are available online. They call them the 2021 treatment recommendations, but they actually just came out this year. So they are hot off the press treatment guidelines for STIs in multiple populations, but including our own. So what I really also wanted to point out, on the CDC website, they have a lot of great resources that we can use directly in our facilities and at point of care in taking care of patients. They have a wall chart, which is kind of a large poster that can be printed to put up in our clinical office or space to be able to think about types of infections and common treatments. They have a pocket guide that you can print out, keep with you. They have a PDF version, which you can have, and then perhaps I think most useful for many of us is an app that they've developed to really have that guide with you at point of care when you are, working with somebody, thinking through, is this an STI, to really be able to just go into that app and have that information at your fingertips in real time. And so that's available through the various download stores and on Google Play. Another resource that I wanted to point out that the CDC has on this website is what they call their customizable announcement. And what this is they put forth a letter or drafted a letter template that providers, clinicians, facilities can use to educate their community, their patients, the families, the caregivers, the clinicians about these new guidelines, about why do these guidelines matter, how does this impact our population, our community, and it's an editable document. So the CDC allows you to, download the document, and then you can personalize it for your institution, your community, but have some of that templated language already there to kind of make it a little bit easier for you to share directly with your community. So some things to think about specifically when we are thinking about the possibilities of STIs in potentially with our patients. First, as Dr. Green pointed out, discussing sexual history, discussing sexual behavior is key. When we're thinking about diagnosis, we want to test all symptomatic patients. When we're thinking about testing, we want to keep in mind that co-infection is quite common. And so if we're thinking of one STI, perhaps based on the symptoms or the signs that we're seeing, we really want to broaden that out in testing to screen for other STIs as well, and consider that initial treatment to perhaps cover other STIs additionally. Asymptomatic infection can be common, and that can be a big part of increased risk of transmission. So if we do identify high-risk individuals, then we want to think about testing even if asymptomatic. We want to examine and test all anatomical sites that are involved in sexual exposure. So we really need to have that open, honest discussion, non-judgmental relationship with our patient to work through, what sites should we be testing and what should we be looking for. When we're thinking about testing, there are kind of 4 generally different types of testing that we're thinking about. Vaginal secretions can be for trichomonas. When we're looking at urine, most common test is the PCR-based test for chlamydia or gonorrhea, that's tested together. Skin lesions, we're often doing a culture for herpes simplex virus or HSV. And then blood, commonly we're looking at HIV or hepatitis B, syphilis, which is a multi-step test as well. Some general tenets of treatment. Again, treatment can get very complicated very quickly, and so we want to make sure that we're using the resources that we have at point of care to make sure we're making the right decision for our patient. If we're testing, we're treating. That's kind of one of the tenets of thinking about STIs. If we're going to test someone and we're thinking about this being an STI, CDC recommends initiate treatment while you're waiting for those lab results to come back. Additionally, treat symptomatic high-risk patients or asymptomatic patients who have a known exposure or have been sexually assaulted. Again, the treatment guidelines are available from the CDC, both on their website and in the various forms that I talked about. I think what's perhaps most useful for most folks might be that app that they have to just be able to look it up real time right there on our device. When we're thinking about treatment, we're thinking about community. So we want to certainly test and treat our patient, but we also want to test and treat partners of any patient that has an STI. So we have to be very focused on contact tracing, who else may have been in contact, and that is something that the health department can also assist with. We want to ensure compliance to treatment. In many of our facilities, we're already, administering medications, but if not, perhaps, then thinking about, could we do directly observed therapy? Is that possible? And in terms of compliance, trying to get the simplest, most effective, but simplest regimen will also increase compliance and adherence to treatment. In terms of following up, certainly repeat testing if recurrence of symptoms happens. If a patient's low risk, then you can repeat testing, even if they're asymptomatic, around 3 months. But if they're high risk, then it's recommended at 4 weeks. And those are some of the resources that I wanted to present that you all make sure that you're aware of, that the CDC has these great resources to use and that can be helpful in point of care. So with that, I would open it up to questions, and Dr. Green, if you have any other comments as well.
Thank you. That was a great review. And I've got the chat open if you have any questions that you want to put in the chat, or I don't know, Anthony, if they are able to take themselves off mute. Perhaps you've had some cases that are challenging for you that we can be a resource to bounce ideas off of. Please feel free. This is a time to do that.
I have a question. So I guess thinking about long-term care and a resident maybe with some extent of cognitive impairment, or even if it's another kind of a congregate setting where folks may have developmental disabilities, where along that line and how do you kind of care plan and build into their overall care the ability to make decisions about their sexuality? And is that kind of there must be some balance between free will and the ability to make their own decisions. What are your thoughts on that, Dr. Green?
That's a great question. So when Dr. Archbald talked about asking those questions, I think people are they're more expectant of a very thorough review of their history on initial visit. And so even though I know we're busy, when you do that initial visit, right, that's a time to get a very thorough history. And I tell people, listen, I know these may be some nosy questions, but I want to make sure as your physician or your healthcare provider that I know everything I need to know about you so that I can take the best care of you. Okay. So I think it's important on that initial assessment, if the person just moved into the assisted living facility or they just got assigned to your team, you can sort of screen for risk factors on that initial visit, not only for sexually transmitted infections, their sexual history, but also cognitive screen. So that's bread and butter for the comprehensive geriatric assessment, determining if they've got some memory complaints or if they have some issues that maybe they're not aware of. You're going to do that as part of your initial geriatric assessment anyway. So if you have someone with with risk factors for sexually transmitted infections and some cognitive impairment, then you know you need a care plan around that. Obviously, that takes time. You may identify it on the first visit. You will not have time to deal with it on the first visit. So then you plan and say, let's sit down again in the next couple of weeks after you've had an opportunity to get settled, and then we can have a care plan around how things are going. You can bring it up at that time. If you miss that initial assessment window, another great place to do it is the annual Medicare wellness visit, because everybody gets those. And if they are in long-term care, there are those required regulatory visits, right? Which are sort of like chronic disease management visits. So those are opportunities to revisit health maintenance and prevention, of which this is an important part. Now, to your point about cognitive impairment. So the way I talk to people about it is I say, listen, just because you have some cognitive impairment does not mean that you don't have the capacity to make any decisions, right? So decision-making capacity is a clinical skill, and we do it all the time at the bedside. Competence is a legal determination that requires judges and lawyers and 5 pages of paperwork, right? We're talking about decision-making capacity, which is a clinical skill. And so capacity is situation specific. And so what the analogy I will share is a person may have some cognitive impairment, may not have the decision-making capacity to consent to a CABG, right, to coronary artery bypass. That's a big surgery. But they do have the decision-making capacity to consent to a blood draw. It's a different situation. And so I think it's important to ascertain Does the person understand the choice that they have to make that's before them? Can they articulate values and beliefs around that choice? Do they make a choice that's consistent with those values and beliefs? And is that choice consistent over time? Right? You don't have to agree with it, but if they can demonstrate each one of those things, then they may have capacity to make a decision about that particular issue. And when in doubt, engage a surrogate decision maker, because that's the safest thing for the patient and for you as the clinician. I hope that answers your question. If not, you can ask me a follow-up and I'll try to get closer to the answer.
No, that's great. Thank you.
I guess I do have a follow-up question on that, Dr. Green. I think, well, I love the way that you distinguish between capacity and competence, right? So really, in terms of our lane as clinicians, it's capacity that we're talking about. When, there's a question of capacity or not, but we're thinking about engaging the family, or the surrogate decision makers, whoever that may be. How do you approach that with the patient, and how do you approach that with the family?
Mm-hmm. Very good question. So I believe in operating in a way that shows respect for persons, regardless of their station or stage in life. And so if I feel like there's something that we may need to pull a surrogate decision maker in about, I will tell the patient in a one-on-one and ask their permission, even though they've got a documented medical power of attorney. I will say, is it okay if we bring your daughter or your son into this conversation? I think it's important to have them involved here, because I want to make sure that we're doing the right things for you, and they know you so much better than I do, right? So I don't just assume that because a person has a diagnosis of dementia and a medical power of attorney that I need to bypass the patient and go straight to the medical power of attorney. I always ask permission, even if I'm just changing somebody's medications, right? I'm just replacing a potassium or something. Always go and talk to them about it and say, hey, I'm going to give you a little bit of extra potassium, or hey, I'm going to have them put a banana on your tray every day, because it gives them an opportunity to be involved. Now, for talking with the family member, sometimes you've got to tee that up, especially if it's a sensitive issue. So for example, I had a patient in my nursing home who is transgender and wanted to prefer pronouns were she, her. There was an adult daughter that needed to communicate with me. And so I asked my patient, is it okay if I talk with your daughter? Right. And when I spoke with the daughter, and the patient said yes. So when I spoke with the daughter, I realized that I was using the patient's preferred pronoun, she, her. The daughter was saying him, his, because she grew up with him as her father. We talked about that. And she said, I know I accept the choices that my dad is making, but he's always going to be my dad. And so that's just how we do it. I say he, him. But I wanted to make sure that even in that conversation, I was respecting the way the patient wanted to be viewed. And so it was just a sidebar. We're going to talk about the diabetes and the hypertension and all of that, but let me just make sure that I'm showing respect for not only the patient, but for you, by acknowledging that, you may have some sensitivity around this issue.
Thank you. Yeah, that's wonderful.
And so
Oh, go ahead, Anthony.
Do you find that I guess potentially in this type of a situation, then you're talking to a resident's family, and potentially another resident and family of the person they're attracted to,
Right.
or involved with.
Mm-hmm. we have to engage both. And that's actually with any incident, right, that occurs in long-term care. I was on call this weekend for my practice, and they called me to tell me so-and-so kicked so-and-so, and I had to make sure that that they notified the family members of both sides of the altercation. So even in amorous relationships, we want to make sure, especially if there is cognitive impairment involved, that you're engaging both families.
And then, so from the standpoint of just the disease process, or with a sexually transmitted infection, I guess this is a multi-part question. One, I presume, and I feel like this is the case, and I may be wrong, but that someone could have an underlying sexually transmitted infection asymptomatically for some years. And I wonder, could that resurface in the context of a suppressed immune system? And or is that
Yes,
ever a
we'll just say
challenge?
that.
Is that ever a challenge with respect to the person may come to you with complaints that are consistent with a UTI? You dig a little deeper and also look for a sexually transmitted infection, and they have both a sexually transmitted infection that's just been there for years and also a new UTI. Is that a situation that you face?
Perhaps not specifically with UTI, but you can certainly have asymptomatic infections. I'm trying to think of any examples that I've seen in that situation. It take me a second to see what I can come up with, but I mean, I guess at the heart, it comes down to, diagnostic decision making is complicated, right? And so when we are taking a history, we need to be both, thorough and direct. So getting the big picture, as well as really drilling down specifically on history, symptoms, evaluating for signs. And then with any test that we're doing, think about, the likelihood of that test being positive, the likelihood of that test being negative, how much we think that is going to impact our decision, even before we're testing. But it's possible to have a chronic infection or asymptomatic infection that's been there for a little bit of time, and then symptoms that might be related to something else. So Dr. Green, you're muted.
Oh, I was just talking to myself. I was saying, yeah, like the person who has, tertiary syphilis presents with some cognitive impairment. That might be part of the workup of the cognitive impairment. And we would also test for a UTI, because that's what we do when people have cognitive impairment. And you may find that, yes, they have a UTI and their RPR is positive. So you got two different issues. So we just have to keep it broad and make sure that we're thinking about all the possibilities.
Mm-hmm. And just a note back to our session last month, we talked about consideration of urinary tract infection and dysuria. And so we had Dr. Robin Jump join us for that. So if anyone's interested in thinking about the workup and diagnostic of potential urinary tract infection, I would also recommend checking that out, because I think she did a phenomenal job of walking us through that. Great. Other questions from the group? Either feel free to unmute or put in the chat. Questions, comments, concerns, experiences? I do have a question, Dr. Green. So, so you mentioned that, on an initial visit with a patient, going in and you yourself having, a comprehensive evaluation of many different aspects of that patient, their health and their life. Do you have any kind of tips or advice on how we can also, work with our staff to also have kind of a comprehensive evaluation, an open discussion, a non-judgmental environment created, so that we ensure that all parties involved in care of this patient are, taking care of the patient?
Yeah, that's a really, really good question, because as well as I do that in long-term care, we've got a lot of turnover. It's high touch work. It's challenging. It's often not compensated at a level that people can actually earn a livable wage. Oftentimes those frontline caregivers are underinsured or uninsured and may have to change jobs because of that. That also contributes to the turnover. So I find it really challenging to train staff in a way that sticks just because of the turnover. However, I think the best way to do it is to model it for whoever's in the building at that time. And so one of the things that I do, for example, is I don't have an office here in my nursing home. That's why I'm doing this in my car. I don't have an office. But what I do is I stand at the nurse's station. And that's where I chart. That's where I get myself organized. What it allows me the opportunity to do is to hear the banter back and forth. I can ascertain whose daughter's upset, whose son is coming in, what's going on with the patient. So for example, today, when I went over and to check on one of the units, they said, oh, we really need you today. We've got some problems here. And it was about someone who was having some sexual expressive behaviors. And so they said, oh, this person is off the chain and you really need to do something. And so I said, well, tell me what exactly is it that this person is doing? And one of the nurses said, well, he asked me if I like to fool around. And I said, oh, so he finds you attractive, right? So reframing, I know that it's not appropriate for the setting. That's why I said that I don't like the term sexually inappropriate. It's socially misplaced sexual expression, right? So he's finding you attractive. I'm not excusing the behavior, but I am trying to broaden their understanding that these patients are still sexual beings. So we need to think about that as we're caring for them. So one of the most effective ways I found to train staff is to just model it for them. So when we're talking about it and they're explaining what's going on, I tell them, explain to me what's happening in the situation and let's talk about what may be going through his mind or what may be going through her mind when you're in the shower room and you're trying to clean them up. Let's talk about what it looks like to them, what the experience is for them, because they don't have the capacity or may have limited capacity to change their behavior. You, as the cognitively intact person, have more control over the environment and the stimuli in that environment. So I do a lot of elbow to elbow teaching in the moment for whoever's in the building at the time, because you can do an in-service and next quarter, half of those people are gone.
Yeah.
So it's this constant re-education that I think is best done shoulder to shoulder in the trenches.
Yep. All working together for the same goals.
Mm-hmm. That's right.
Wonderful. Well, great. We'll put a final call out to the group to see if anyone else has any questions or comments as we're wrapping up here. All right. Well, seeing none, Dr. Green, thank you so much for joining us today. It is always a delight to talk with you, and I am very appreciative of you joining us from your lovely office of your car to share your experiences and insight with us today. So thank you so much for that.
Thank you for asking me. And hi, Michelle. I thought that was you. Michelle and I've worked together before.
Phenomenal over at Dogwood.
Yeah.
Your legacy lives on.
Excellent. Thank you, Dr. Green. So there's a slide here which is tells you how to claim credit. I'll send out an email to the group over the next few days reiterating this process, a recording of all of our sessions thus far, including this one. And we have one more for this calendar year, November 15th. It's basically the topic is teamwork and bringing the team together for infection control to kind of tie up loose ends over that topic for the year. And then moving into 2024, in January, we'll start a 2-part series on long COVID. So that should be interesting, as that is a hot topic at this point. So I appreciate everyone's time. And I know everyone's busy in the middle of the day to attend a webinar. It's much appreciated. So thank you very much.
Thank you all.
Bye now.